Do you ever stare at delegation questions thinking, wait, can an LPN do that? Should the UAP do that? Or does the RN need to handle this? You're not alone. This is one of the top areas students miss on the NCLEX. So today, we're going to simplify delegation and show you how to choose the first patient you must see using frameworks instead of just guessing. So this is lesson 4 of our clinical judgment series. So let's get started. Now, delegation is not about what's easiest. It's about what's safest. So here's the mindset. The RNs handle unstable, unpredictable, and high risk situations. LPNs handle stable patients with expected outcomes. And your UAPs handle basic non clinical care. So if you can memorize only that, delegation becomes logical. You'll go from being confused to thinking, oh, this is definitely the RN's job. So, what does an RN do? So, the RN is the only one who can do anything unstable, unpredictable, or requiring critical thinking. And so, those responsibilities include initial assessment, admission assessments, discharge teaching, creating or updating the care plan, IV pushes, except saline flushes, blood transfusion administration, titrating drips, unstable patients, post-op, less than 12-hour patients, new diagnoses, unexpected changes in vitals, interpreting labs, evaluating responses to treatment. So think of the RN like the driver. They're responsible for direction, decisions, and safety. Now, what do LPNs do? They care for stable patients with expected outcomes. So, stable, expected, predictable. So, what are the LPN's responsibilities? Reinforced teaching, not initial teaching. Routine medications, oral, IM, or sub-Q. Some IV medications, depending on facility rules. Sterile dressing changes, Foley catheter insertions, collecting specimens, monitoring stable chronic conditions, identifying normal versus abnormal findings. But the RN interprets. Okay. So the big three things LPNs cannot do: no initial assessment, no initial teaching, no triage or unstable patients. So think of LPNs as excellent clinical partners who keep stable patients safe and progressing. Okay. So what can a UAP do? What's their responsibilities? So the UAP focuses on basic, non-clinical tasks that do not require judgment. So a UAP's responsibilities include ADLs, like your bathing, your grooming, toileting. They help patients with ambulation, feed stable patients, they weigh patients, they perform vital signs on stable patients, they collect intake and output, they help with positioning, and they can assist in CPR. Yes, this is often on the NCLEX. Yes, UAPs can help with CPR. So what can a UAP, unlicensed assisted personnel, what can they not do? They cannot give meds. They cannot perform sterile procedures. They cannot do assessments. They cannot handle unstable patients. They cannot feed patients with dysphagia. They cannot report interpretation of vitals. They only can report the number. The RN does the interpretation. Okay. So a UAP help maintain safety and comfort while the licensed staff handles judgment and clinical risk. All righty. So prioritization. Who do you see first? Okay. So patient prioritization always uses the three frameworks. ABCs, Maslow's, and trends. Okay? So let's try a case scenario. Who do you see first? So you have four patients. You have a COPD patient with respirations 32 and accessory muscle use. You have a post-op day one patient with pain 8 out of 10. You have a diabetes patient with a blood glucose of 310 milligrams per deciliter. And you have an elderly patient who fell yesterday and is now confused. So step one, ABCs. Who would you see first? You would see patient one first. That COPD patient that's having respiratory distress. All right. Second, you'll look at Maslow's. Patient four. Okay. That elderly patient with that new confusion. You would see them second because they fell and now they're confused. So you're wondering what is causing that. Then the third patient, well, the third step would be physiologic. So that would be patient number three, the one with the high blood sugar. They're stable. They have a high blood sugar, but they're stable. And then the fourth step would be comfort. And that would be patient two. The person has pain, but they're stable. So that's who would be seen. So let's do another case. Now, I have what, the duties are for each. And so I'm going to name some tasks and you just kind of write down who do you think this will be delegated to? So number one, educate a new diabetic on insulin use. Number two, reposition a stable stroke patient. Number three, give oral medications to a stable CHF patient. Number four, assess new chest pain. Number five, obtain vitals on a post-op patient vomiting blood. Number six, perform sterile wound care on a stable surgical incision. All right. So the RN, they must do the new teaching. They must do the chest pain assessment. They must obtain the vital signs for an unstable bleeding patient. The LPN can give the oral medications for that stable CHF patient, and they can perform sterile wound care. And the UAP, they can reposition that stable stroke patient. All righty. So when we're looking at that delegation decision formula, think of it like this. If it involves assessing, teaching, evaluating, or an unstable patient, that is always the RN. If you're looking at a predictable and stable patient, that's an LPN. And if it does not require clinical judgment, that's your UAP. This formula alone can answer approximately 80% of the NCLEX delegation questions. So try to keep it to memory. All right, let's do a mini challenge. Who do you see first? Who do you delegate to? So you have tasks and you have patients. All right, I put the answers on the screen so you can look at it later. But okay, A, the patient is with a low blood pressure, 88 over 54, with a heart rate of 122. The B patient is a stable COPD patient needing morning medications. C, you have to ambulate a patient post-op day two. D, you have a patient with new confusion and fever of 102. And E, you have to teach a patient new ostomy care. So you have the prioritization, and then you have who is delegated to. So you're going to see patient A first, that patient possibly going into shock, and the RN will see that patient. You will see second patient D, the one with the confusion and the fever, maybe possible sepsis. I don't know. They felt, it's possible sepsis because of the fever. So you'll see them second. Number three, the LPN can see that stable COPD patient needing morning medications. Okay. Number four would be seen by the UAP to ambulate that stable patient post-op day two. And then E, number five, would be the RN doing that new patient teaching for the patient with the ostomy. Okay. So to wrap it up, delegation, really becomes easy when you stop guessing and start using logic. So remember, RN equals unstable, new, assessing, and teaching. The LPN equals stable, predictable, and routine. Your UAP equals basic care and requiring no clinical judgment. And then remember prioritization. Your APCs first, then your Maslow's hierarchy, and then your patient trends. And so that's it. You know, please visit NurseEdScholar.com to download your clinical judgment and prioritization workbook. It includes, delegation exercises, practice scenarios, and rationales. And please don't forget to like, subscribe, hit that bell so you don't miss lesson 5. Um, I'm going to go over medication safety, made simple. And remember, you are one step closer to passing the NCLEX with confidence. Keep going. I'm really cheering for you. All righty. So until next time, thank you for visiting Nurse Ed Scholar.